I am ready to rock.
We're gonna do, is this 8 minutes?
I'll do 10.
10? Okay.
Hi,
So,
everyone, and welcome to the show. We have the perfect trifecta that sparked a critical focus on equity and care for a disease that is more prevalent and deadlier than all cancers combined, except for lung cancer. It's known as peripheral artery disease, which is poor blood flow in mainly the legs. That left untreated, it can lead to amputation, it can lead to stroke, it can lead to heart attack. And people of color are up to 4 times more likely to have their limbs amputated because of this disease than their white counterparts. And since February is Black History Month, American Heart Month, and Saturday is PAD Awareness Day, peripheral artery disease, PAD or PAD, we are going to talk about some of the reasons we think that people of color are getting their legs amputated at a much higher rate than their white counterparts, and maybe offer some thoughts on what can be done about it. We're going to cover a lot of topics that are important to all of us that I think will really open your eyes to the experience of people of color with PAD care. And there are a lot of gaps in care, and we're hoping to address ones today that really have not been discussed very much. We already know that there are gaps in terms of access to care, access to food, financial barriers, insurance barriers, and all that jazz. But in the next hour, what I really like to focus on is really what you don't know about experiences in the African American community. We're going to talk about the historical and cultural differences, maybe some communication gaps, and what we call the deception of the Black foot. That's going to be a very interesting conversation that's going to lead to possibly what we hope are educational changes for physicians who are treating people of color and possible wounds, especially diabetic wounds. We do have an amazing group of people of color with PAD and their family members who are here and ready to share their personal journeys and lessons along the way. And you're going to hear them, chime in throughout. But first, I want to say hello to John. Hello, John.
hello, Kimberly. How are you?
Thank you. Yeah, I'm doing really good, really good. Um, I heard you had a big day today.
Yeah, I'm in the in my office in the cath lab right now, and I just spent some time trying to. Interestingly enough, you bring up the difficulty kind of sometimes assessing a wound in someone who has darker skin tones. And the patient that I had just did a procedure on, which this is another minority that we don't see. This was a Hispanic male who had some toes that are gangrenous, and so they're kind of dying on him. But I think they were missed a little bit because he has darker skin, and I'm not sure people were kind of thinking, putting two and two together. So this is a great topic, and obviously, peripheral arterial disease and cardiovascular disease, it's not racist at all, right? I mean, it doesn't care what color you are, because it affects people all of any race and ethnicity and socioeconomic fraction. But I will tell you that what we need to do a better job of, and what we're trying to do through this conference on Saturday, is raise awareness for everybody. And obviously, we're focusing on African Americans, but people should not be getting their legs removed at the rate they are in 2024.
No, I totally agree. And I want to bring in first, we have our DEI, our Diversity, Equity, and Inclusion Chairman for the Global PAD Association, which is our nonprofit that supports people with peripheral artery disease. He's been doing a lot of research and preparing, for Black History Month, American Heart Month, Pat Awareness Day, and our PAD, the Lived African American Experience event. And I want to say hello, welcome him in, and to share his thoughts. Hey, Charles.
Hey, Kim. Hey, Dr.
How you
Phillips.
doing?
I'm great.
Charles, how's it going, my friend?
Everything is everything, Doc.
Well,
That is
good.
true. That is true.
So I want to, jump right in, Charles, because you've done, quite a bit of research. And as we've been preparing, for this conversation, one of the issues that we find, in the African American community is there's just this general mistrust in the healthcare system. And you had recently written a blog post on padstories.com, about some of the reasons why this may still be an issue. Would you mind talking about some of what you learned?
Well, yes, it's historical that African Americans have been misused in America as a whole, but especially in the medical field. We've been test subjects without our permission. And one of the most famous or infamous ones was the Tuskegee experiment, where they gathered up 399 men of color and infected them with syphilis,
Oh, wow.
with claims that they were healing them. In fact, they were not. They were just test subjects.
Wow. And,
Yeah,
is that something that as you were growing up, that was ever brought up in your household and impacted your perception of the healthcare system that you
it,
have today?
it was not specifically, but there was a lot of times that instead of going to the doctor, we would use more home remedies
Mm.
instead of going to the doctor. And my parents and grandparents never explained why, but later on I've learned the reasons why.
Really, was that something that so your parents never really talked or put two and two together for you with that? It was just something that you started reading up later and going, oh, you know what? I betcha that's why we didn't really go to the doctor very much.
Absolutely, yes.
And I know that we had Elizabeth on here just a little bit ago. Elizabeth had, um, also some issues when it came to, and still is having issues when it comes to, trusting the healthcare system. And I'm wondering if she's still, with us and on. But Larry,
Actually, hey Kim, is it possible? I've got a little color behind the Tuskegee. Well, they called it the Tuskegee syphilis study.
yeah,
Can I share a little bit of information behind that?
yeah.
So this was conducted. I'm just kind of the nice thing about it is I watching the Super Bowl. I downloaded Copilot, the Microsoft app for ChatGPT version 4, and I actually just asked the ChatGPT, tell me a little bit about the Tuskegee experiment. And so this was quote a research, and we've got about 2 minutes left, so I'll be quick. But it was a research experiment between 1932 and 1972. It was conducted by the United States Public Health Service and Centers for Disease Control and Prevention, the CDC. And they were focusing on a group of 400 African American men with syphilis. And really, this is directly from the study. The purpose was to study the effects of syphilis when untreated. But what is a travesty is by the end of the study, medical advancements had occurred that made syphilis entirely treatable. And they enrolled 600 African American sharecroppers from Alabama. And, 2/3 of them had latent syphilis. And the problem there was deception and lack of informed consent for the patients, right? So they weren't informed about their diagnosis of syphilis. They were often disguised as placebos, and really they had ineffective treatment methods. And frankly, at the end, these folks could have been treated. And that's just it's very difficult for any individual to then trust a healthcare system when you're kind of purposely deceiving them and not informing them to the best of their ability so that they can make good. So definitely ethical violations and just a sad stain in medical research in the United States at the time.
And I just wonder, I mean, I can kind of compare that just a little bit to what we're dealing with right now when you have, more than what is the number? More than 60% of all amputations being performed without even an attempt to restore inline flow as per society guidelines, and 90% of which the patients aren't even offered a vascular evaluation in the year prior. I mean, how do you continue to trust your doctor when this is the case? And you can't say that they're actively deceiving the patient. I mean, but I would think in today's day and age that at least in this case, I would think that even if that one doctor doesn't know,
That is,
what the doesn't offer the options, that they would know that there are options available for that patient, even if they don't agree with it. They would at least give the option to the patient and say, I don't agree with it. I don't think your leg should be saved, but you know what? There's a doctor down the road. You're welcome to check in with him or her.
that is a provocative question that we'll answer when we get back from the break. So stay with us.
Perfect. Nice.
Look at Kim. I'm learning.
I love it. I think you did a great job. I wish I had one of those little clapping sounds.
I know.
Nice job. Nice job.
So that was 10 minutes.
That was 10 minutes about, right?
10-minute segment.
Okay. You want to bring it back? What I was thinking is that we get to Charles, what do you want to, jump in as well with Dr. John, and then we should bring in Elizabeth and her story a little bit, and then Larry on the rounding out that discussion. And I don't know, and Amy, just make sure, like, if you guys want to jump in and we're not calling upon you, just say, hey, can I say something? Hi, it's Amy. Here's a little bit about, or Douglas, say, hey, this is Douglas. Just wanted to add a little, thought here. Dr. Jones, say, hey, I'm Stacia Jones, Dr. Jones, podiatrist. Jump in here. Elizabeth, same, so that we don't, if we don't call on you, we could just make it more of a discussion. Just when you speak, just make sure that if we don't introduce you, you just, charge on in there and say who you are and what you think.
Do you want to go into the question you posed before the break?
Sure. Do you want to answer that question?
Sure, I'll do my best.
Do you want to bring us back, or?
Why don't you bring us back? Because you can pose the question to me, and I'll try to come up with something clever to say.
Yeah, and I think that Charles might want to jump in, and Stacia actually might even want to jump in on it.
Fire away.
As well. Okay, here we go. 3, 2. Hi, everyone, and welcome back to the show. We are focusing on PAD, the Lived African American Experience, because it is Black History Month, American Heart Month, and PAD Awareness Day on Saturday. And so before the break, we were talking about an historical situation that has led to many in the African American community here in the United States to have even still a mistrust in doctors, or at least historically a mistrust in doctors. And I was making the point, Dr. Phillips, Dr. Jones, even, Charles, or DEI chairman for the Global PAD Association, that I'm just wondering if maybe there's a little bit of that today. Maybe it's not an intended deception, but when you're talking about more than 60% of all amputations happening, the highest being in the African American community, without even an attempt by society guidelines to restore inline flow prior to amputation, 90% of which are done without even a vascular evaluation at all. Do you think that there is a little bit of a deceptive practice there as well? Maybe not intended, but I would think that in today's world that every doctor would know today, I would hope, that that there is the potential that arteries could need to be opened, and that they should do a vascular evaluation.
This is my disclaimer. These are my thoughts and opinions only, so take it for what it's worth. To use the word deceptive, I shudder at that, and I don't think that that's the case. I think there's a lot of factors that play into treating somebody with peripheral arterial disease, which are a little bit different than those of coronary disease, for example. But one of the things that I struggle with is lack of awareness to the disease process, both by physicians, so primary care doctors, cardiologists, people in my field, surgeons, etc., and then the patients. Like we've talked about that, and that's kind of why I we do Save My Piggies and you do what you do just because we're trying to raise awareness. I think one of the other things that drives, people to get pushed in a certain category of not having a vascular evaluation or an angiogram is just maybe not comfort level or adequate expertise by the physician in that particular field. And then you couple that with most of us are alphas and we have big egos and we're not willing potentially to kind of say, hey, I don't know that I can do this, but maybe I should give it to somebody else. So that's one of the drivers, I think. And it just goes to show that we have a long way to go. We have to continue to keep pushing this agenda of education, this agenda of prevention. There are so many modifiable risk factors that we all can get behind and try to help this. Because let's be honest, you have a 50% mortality at 5 years if you have critical limb ischemia. 50%. I was at an advisory board where we're talking about stents that break up and they're bioabsorbable and they kind of absorb over 3 years. And we said, well, if you think about it, who cares? Because a third of these people are dead within a year, and probably 40% are dead within 4 years. So we've got to get better at educating. We've got to get better at preventing this. But patients have to be their best advocate, and they need to speak up and don't take no for an answer. Meaning you're not getting this, and you're going to have an amputation. There's no way that should be the primary diagnostic treatment plan is a primary amputation, unless if it's so far gone that there's just nothing viable.
You guys can jump in and you don't have to wait for me. I see Dr. Jones wants to jump in, and then I think Charles and also Elizabeth.
Yes, ditto a little bit off of what Dr. Phillips said. I'm glad you brought up that point about doctors' ego and things like that, because I have a male coworker and we're very competitive. And so I always tease him because I steal his patients because I get all his patients' ulcers to heal quicker than him. And he won't outsource it. If he can't heal the ulcer, he'll just keep seeing it. I'm like, you're still seeing the same patient? All my patients are healed. So it's like that competition because, I'm a female, he's a male. And so I do see that with him especially. But I think it's a combination of factors. I do think as African Americans, I think it's certain diseases that are more prevalent in our community, like I don't know why I'm drawing sickle cell anemia and kidney disease, but I don't think like PAD is at the top of the list for us unless we had a family member that's already had an amputation. So where I work, I have a diverse population of patients, but I do have about 40% of my patients are African Americans. And the first thing they say, oh, I'm newly diagnosed diabetic. I don't want to lose my limb. So, and they'll say because I had a family member or this person, but in all honesty, most of the conditions that really affect us that we focus on, I feel like, is sickle cell or kidney disease. And so I think as African Americans, we need to really get the word out for PAD and how it does affect us more so and having blood clots in our legs. And also, like you said, it's some of the doctors, patients nowadays, because there's not as many doctors as there are patients. So you have a lot of nurse practitioners, you have a lot of PAs, you have a lot of others that are in the healthcare field helping doctors. And so the patient has to be their primary advocate. I can't wait for us to hear Larry's story because he's currently going through a situation right now where he does need help and he has had some studies, but it's still not getting him to the next stage. So I think, this whole process will be able to help him, and hopefully we have a happy ending for Larry and he will never lose any of his limbs.
And just real quick, lifetime. So African Americans, both male and female, have a higher lifetime risk of getting PAD than Hispanics and whites. And they also get it earlier too. The data suggests we're seeing patients in their 40s that have PAD, which that's got to stop. And so that we have to get better at identifying it in African Americans. and underrepresented minorities, and then trying to figure out how to prevent its progression.
Are the
Yeah, I know
40-year-old
that Larry wants to
smokers?
jump in.
Have you seen the 40-year-olds have a history of smoking?
I would have, again, I don't know that obviously tobacco is risk for it, but I think just in general, that the African Americans have a higher risk and prevalence of PAD than any other race.
But
And I've
why
had
is
several with chronic kidney disease that have had it. And Elizabeth?
Yes, my question to Dr. Phillips, why is that?
I don't know. I think it probably this is just my opinion. It may stem from delayed treatment, whether it's going to the physician, trust in the physician, getting, that relationship developed. African Americans tend to have more hypertension than their white counterparts, so hypertension is a risk factor.
Yeah.
But again, too, it depends. I think there's socioeconomic forces at play as well.
Also,
Well,
our blood is thicker.
I tend to disagree with that because in my situation, I was middle class. I trusted the doctors. All my life, I went to the best doctors in New York, North Carolina. But what I found in North Carolina is that a lot of doctors have illicit biases against African Americans to even diagnose them. For example, I would go into a doctor, tell them that during a stress test, I stopped because my cast was hurting, and I was told you just have to work through it.
Wow.
I'll see you in 6 months. Okay, so I don't think that it's because of African Americans, I really think there's more to it. I believe, and you may not take this, and I hope I don't offend anyone, but I believe that there's a lot of illicit biases within the medical community that will view us less than and treat us less than.
And I'm curious, you're not alone in your perspective. I know that we've had several in our planning sessions leading up to this event. Charles might want to weigh in. Charles?
Yes, real quick. I just want to jump in and say that historically, it's been thought in the medical field that Black people had a higher pain tolerance than our white counterparts, even to the point where they call him the father of OBGYN, that he was doing procedures on Black women without any anesthesia because of this belief. And somehow, even through this to this day, that we do have those biases, that we can handle more pain because of our skin color, and doctors are not as urgent to treat or listen to our stories of pain.
And I want to get more into that because I can see that Elizabeth and also Dr. Jones are nodding and wanting to jump in on that. And we have to get to a break, but we're going to jump right in to that topic a little bit deeper in a moment right here on the Heart of Innovation. So stay with us. Okay. John, you want to bring us back and go right into, I know that that's a really good, Charles, I hope I don't know if I cut you off completely, but if you want to, finish what you were saying. And then we have both Dr. Jones and Elizabeth that were wanting to jump in there, but I'm going to get the clock set. And Dr. John, would you like to take us back?
How many, is this another 10 minutes?
I think that we'll make this about 8.
8? Okay. All right. Let me just get that real quick. All right, ready? Three, two, one. Welcome back, everybody. Thanks for joining us. Continuing a very provocative discussion regarding peripheral arterial disease and its prevalence and treatment disparities within the African American population. I learned something just before the break. I'd never heard or been told that there's a perception that African Americans have a higher pain threshold than anyone else. That's kind of blows my mind, frankly. Dr. Jones, have you heard that?
Yes, I have. I follow a lot of African American doctors on Instagram, and I follow this one kid. He was just on Good Morning America or something. He's posting a lot of trauma and biases that African American patients have faced throughout the years, starting back to like 1950 in medicine and in healthcare in general. He's actually in medical school right now. So yes, and I have friends that are doctors. I've had friends that, I've experienced it, of course, being a Black female doctor myself, my own biases. And, I come in a room with one of my classmates and they automatically think I'm the nurse, even though I have a white coat. And then my male counterpart is automatically called a doctor. And they ask me, they're like, "Oh, Nurse Jones, can you?" And I'm like, "No, I'm not the nurse. I'm a doctor too." So I still get it. Patients always think that I'm the nurse when I'm in the room. My nurse seats them in a room. So Dr. Jones comes in and I come in, they're like, "Oh, when does the doctor come in?" And I'm like, "I am the doctor." So it's just things that I don't let it, I used to come up with jokes and make patients laugh just to kind of break the ice. And I used to get offended when I was really young and became a doctor, but it's just so many stories and obviously we don't have time. But I do want to actually address Elizabeth's question she asked earlier. I think part of the problem is African Americans are high risk for a lot of things. We're high risk for diabetes. We're high risk for kidney disease. We're high risk for high blood pressure and high cholesterol. Part of it is culturally how we eat, things like that. And also with the PAD, our blood tends to be thicker. That's why they put people on blood thinners who have issues with their arteries, because our blood tends to be thicker culturally, African Americans. Hope that answers your question, Elizabeth.
Okay, well, I want to expand on what Charles was talking about as far as African Americans, is believed to have more, can take, tolerate more pain. Even though that was, done historically, it is still being done today. Even in 2021, I had a personal experience where I was put on a table to get a procedure and I was in excruciating pain. They did not give me any pain medication, nothing to relax me. When they put the first needle in my back, I'm screaming to the top of my lungs. And what I was told, well, you have to let me finish the procedure, because if you don't, your health insurance is not going to pay for the procedure. Okay,
Well,
so
that
it's
was the
still
concern.
those practices and those beliefs from white doctors are still believed today. It's passed on.
Well, I can just tell you, I've never heard that before. And that's an unfortunate situation. You shouldn't treat, let's be honest, when you open up somebody's chest and do bypass surgery on them, everybody looks the same. When we put our tube in your arteries, they all look the same. So again, I think it's just opportunities such as this to help raise awareness.
Well, how are you going to raise awareness to doctors that are, let's say, biased? And I'm going to go as far as saying they are part of the white supremacists that are treating patients. How are you going to change that? When I walk into a doctor's office that have those personal biases, even though they took their oath to cause no harm, how are you going to change that? When they look at me just as a person of color, a Black woman, or look at a Black man, they're not going to give us the same treatment as they would our white counterparts.
And you have actually a specific example of that as well, Elizabeth, in terms of you are a very highly educated woman who's held very powerful positions in New York that we've talked about before. But And yet, when you've walked into certain doctors, you have found that they question your educational experience and
Yes,
knowledge.
yes, they do. Some of them. I've ran into that situation as well. Um, Example, when I was first diagnosed with PAD, um, the first thing they wanted to do was put a stent in the back of my knee. Imagine that. Put a stent in the back of my knee where my knee is, flexing back and forth. Does that make any sense? It doesn't make any sense to the common person. So when I questioned that, and I wouldn't allow them to even touch me because before they even looked at my records, they wanted to put a stent in the back of my knee. They wanted to take me into the cath lab, right? When I started asking questions, the first thing, are you a nurse? Are you in the medical field? No, I'm not. Are you British? Where are you from? Because,
Weird.
and then, I'm like, all right. I walked out. They went to the ladies to the bath, stepped out. I went to the bathroom. By that time, more patients came in, sitting in a waiting room, and every last one of them had one of their limbs amputated.
Oh, wow. That had to have
Every
been
last one
scary.
of them.
Were they African American or was it diverse?
Mostly.
And so you ended up saying, nope, no, but we have to say that in terms of the, stent in the back of the knee, now more than ever, less is more. They don't use stents as much, and particularly in the back of the knee, they do question whether or not it's really even necessary, because that's a really good area, right, Dr. Phillips, where they can grow collateral vessels or those natural bypasses around any sort of blockage behind the knee. And behind the knee traditionally has been a spot, as you said, where because of the bendiness, the stents don't tend to last as long, although there is newer technology, still not 100% durable.
Yeah. I mean, before I answer that, I do want to get back to your initial question or point about biases. And I think that we'd all agree that we're probably more alike than we are different. And you have to open a conversation with somebody and try to find a connection. There's an interesting book out there called How Minds Change. And it's fascinating because it goes into the psychology behind people's opinions and how those opinions formed, and how you can not necessarily change somebody's opinion, but allow people to kind of broaden their scope of influence, so to speak. And that's what I do with all my patients. I don't, again, I'm not saying this just because we're on air. I don't frankly care what color you are. If you're coming to see me, we're going to treat you as best we can, regardless. And it's unfortunate that these things still exist. But again, you find some common ground, and you go from there.
Coming up
And
right
I
here
have
on the Heart of Innovation, we're going to continue this discussion. There's so much more to say, and we have such a short amount of time, but stay with us. We'll be right back, and we'll dive into more the Heart of Innovation. Okay. I want to get into, I feel it's hard just because, Charles, I would be jumping in more with you, but it's hard with us not seeing you to have you jump in. But I wanted to see if you wanted to weigh in here, because we have 10-minute segment here. I want to be able to get a lot in. And thank you so much, Elizabeth. That was fantastic. Really being candid about the experience. And Larry, I didn't know if you wanted to jump in here. I want to get to Amy as well. Larry, are you going to want to jump in with anything on this one?
Yeah, I was kind of waiting on the question to be restated, so I don't just jump in.
Okay. Well, if you want to jump in, just kind of wave and I'll call on you, because we want to go into, I think in this one, Charles, are you there?
Yeah.
Did you want to get into some of, we should kind of wrap up where we are and then mention some of the other issues in terms of just the communication gap, I think. And then I want to get into, because we also have Amy here with Dr. Jones, and we have even Larry with the color of his foot, that is even an issue. So I want to make sure we can get to that part of the discussion as well, the deception of the black foot and the color of the skin.
Okay.
Kim, bring us back. Bring us back.
Ah, man.
Wrap it up. This is what you have to do. This is why you get the big bucks.
I'm going to toss to Charles on this one.
Who's Dr. Jones?
Nope, Dr. Jones is still here.
Okay, gotcha. I didn't see the camera. Okay. Good.
Okay. I'll just make up something.
8 minutes though? Or 10?
Yeah.
You want 10?
We're leaning towards 10. We'll try for 8. We're out by 10, and we'll just have our producer figure that out. Okay, here we go. Welcome back, everyone, to the Heart of Innovation, Black History Month, American Heart Month, PAD Awareness Day. We are talking about PAD, the lived African American experience, because people of color are getting their limbs amputated at 4 times the rate of their white counterparts. And we're just trying to explore some of the issues that might be leading to this, common biases, including the tolerance of pain and mistrusts of doctors, in the past, leading up to and kind of trickling into people's perceptions even now. I mean, so much to talk about. I want to bring in Charles Winters, who is our DEI chairman for the Global PAD Association. And what are you thinking so far, Charles, about the conversation?
I actually want to go back to what Dr. Phillips was saying about how he treats his patients. I want to applaud him on doing that, but I also want him to understand that that's not the norm in my experience. And I have a lot of medical issues and seen a lot of doctors. Sometimes the doctor doesn't come in and try to find that common ground. A lot of the times they won't even look at you. They're looking at their notes or their iPad and telling you what's wrong before you even get a chance to share with them what we are feeling. And a lot of the communication that goes on is that the doctor is talking to you like you went to medical school, or is talking way down to you like you don't have any common sense. So it's kind of a catch-22, like Elizabeth was saying. When you go in armed with information, they want to know, well, where did you get that from, instead of addressing my problem. And if you don't know and try to get a better understanding, they got so many patients that they're trying to get you in and out, and you leave without having an understanding of what you have going on.
Larry, let me just ask you, do you go into, or anybody can answer this, but do you go into an office visit, maybe it's with a new physician, kind of on the defensive, assuming or being prepared for that type of experience and interaction that you just described? And so, maybe going in right off the bat, there's that kind of, not tension, but the notion that, man, this maybe isn't going to be the right fit for me, or I'm not going to kind of get a better understanding of what's going on.
When I play off of how the doctor comes in and addresses them, you can pretty much tell from the way they come in a room and they greet you and how they treat you within the first few minutes.
Yeah. Understood. Now, do you stick with those physicians, or you try to find somebody else?
Oh, no. Now I'm armed with information now, so I know how to make better choices. But initially, when I started having health problems back in 2013, I would just, whatever the doctor said, that was that was kind of it. Even if they didn't have a great bedside manner, you know, I was there because I was sick, and they're the doctor, so they're the ones that make you better.
And I would like to clarify that it is not only do we have to deal with, let's say, white doctors treating us a certain kind of way. It's Black doctors as well. Okay, there are Black doctors out there just as well as white doctors that will look at their patients as a dollar sign. All right, especially if they have Medicare or whatever insurance that they're trying to milk the money out of. And I've had that experience as well. It was a Black doctor. She's actually doing 25 years in prison because she came into the Black community and she used them for her selfish greed. She was giving them procedures without an informed consent, just like the Tuskegee study, but this is in modern day, all right? By telling them that, oh, well, this is a sinus spa that we're giving you, but not telling us that she was giving us a sinuplasty just to get paid. So a lot of doctors, they're just in it for the money. So a lot of these doctors, I'm talking about Black doctors that come out of medical school, once they learn the system on how to get rich or how to make a whole lot of money, they will come into the vulnerable communities and use them. So it's not only do we have to deal with and be careful of the white doctors, especially the ones that have their own personal biases, we also have to be careful of the Black doctors because we don't know what their motives are.
Right. And so just as with
Absolutely.
patients, I mean, the skin color doesn't matter. You know, that's why I think that this is so important, because we need to really empower people of color, and actually every patient should feel empowered with the right questions, the right information to be able to say, hey, just because you have a white coat doesn't mean you always have the right answers for me, but let's have a discussion and let's talk about, you know, what are the options that you have for me? And then always get a second opinion and a third opinion to ensure that you can make the best and most informed decision based on what multiple doctors have. And I think that that goes to show for everyone. You know, and this is a time where I would just heard on the news out here in the Bay Area that there's this push that we need more, you know, doctors of color that are out here, because that is why people of color don't go to the doctor, because they don't have more doctors of color that are, and that they feel like they could relate to. And as Elizabeth, you know, just shared, maybe that's not really just the answer. And so I think that that's an important point. Yeah.
I believe also just being informed, and we have Dr. Jones here, that there are differences between us Black people and white people, and sometimes symptoms don't present the same in us as they do as our white counterparts. Dr. Jones, can you talk to us about a little bit about the deception of the Blackfoot?
Oh, yes. As far as African Americans, it depends on if they have neuropathy. If patients have neuropathy, they're not really going to be able to communicate. It's all about clinically just knowing, like with Larry, for example, when you guys showed me his picture earlier, you could see the distal tip of his second toe. The skin was darker compared to the rest of his complexion. It was very subtle, but he's also complaining because he doesn't have neuropathy. So he's also complaining that that area is bothering him. So I think it has to be the doctors pay more attention. I get plenty of patients that come to me and say, oh, I went to my primary care doctor and they never looked at my foot.
Oh, wow.
They never even touched my foot, but they complained about their foot, right? And so a lot of patients will say their primary care doctors don't even look at their foot. But I'm in an environment, because I work in a clinic, that just put a referral into podiatry. So of course, when I see them, hopefully I see them in time because my clinic is also booked. I'm like 60 to 70 days for new patients to get an appointment with me. If they document the patient's a diabetic and possibly has like an ulcer, I do put a message to my scheduler that she has to double book my schedule to get that patient in, much sooner. If the primary care takes time to write stuff in their consults, they don't always put extra stuff. They'll just do a diabetic foot exam for me.
And I
But
know
if they
Larry is here. Larry, it was your primary care doctor that said, "Oh yeah, I think you're fine." And
Yes,
it
and they
is
did
your
refer you to
primary care doctor
podiatry.
white?
I'm sorry, I
You
didn't
never
hear.
got a referral to podiatry, even though you were complaining about your toe and your foot.
No, I I went to my primary doctor for a follow-up for something else. And, I was told to always take your shoes off when you go see your doctor,
Good for you.
especially if you have diabetes. Not that I've been diagnosed with diabetes, but he knows about my PAD. And so I, I was having the tingling and the um in
Numbness.
that toe. Yeah. And I noticed when I looked at it, I said, wow, my toe is, the tip of it is turning black. So I showed it to him. And he suggested that it was okay to a degree, and that because if there was a problem, then it would be in my toenail, and that it starts there.
Not
So,
true.
so I said, okay, fine. And make a long story short, that's where that went, and that's why I'm currently trying to reconnect with a interventional cardiologist to get a workup and get things done. But to talk about my experience with why I think that there's this distrust or mistrust between the people of color and doctors. My experience is just simply not like everyone else in the Black community. I had a primary care doctor from the time I was 16 years old in high school, and stayed with him until he retired, and finally found another. So I've only had two primary care doctors in my life, and my experience it's been one maybe of overtrust and not mistrust. I've always had good communication with them, and I believe them. And why lie when you go to the doctor about what you're there for? And I thought they listen and prescribe the right things. But uh, I I want to thank Dr. Phillips and you, Dr. Jones, for coming here taking a beating the way you guys we've been talking about the medical profession, and I'm cognizant of I've heard all these things, but that it's just simply hasn't been my experience.
I will say, Larry, that, and I've told this to Jim when we've been on the show with other shows, that I learn a lot about, patient empathy, if nothing else. And once you create a connection with a patient and you see them as a person and not just a patient, that changes the dynamic of the relationship, in my opinion. And you can, yes, because the patient comes to you in a very vulnerable situation and they're looking to you for some type of guidance and a treatment plan and help, frankly.
Yes.
And again, you find that common ground with that person. I love sports, so we always talk about sports, and I like to cook and food and things of that nature. And once you break that ice, but for me personally, then I see that, yeah, okay, the person has peripheral arterial disease or they have heart disease, but they also are a mom or a dad, or they are a brother, and they're a real human being. They go home and they've got a family, and that to me changes the dynamic, and it makes me think a little bit more sometimes about who it is that I'm treating. It's not just a number, and it's not just another procedure. There's a real human being there, and that might sound silly, but I think some of us kind of lose sight of that.
But
Yes,
doctor,
I
let
agree.
me ask you this, since I have you there. Does the attitude of the patient sitting in front of you affect you in any way that you may not take as much time with them? I don't know, because a lot of times when we go in there, we're kind of scared a little. We don't know what's going on, and and maybe we don't have the communication skills to properly say what we're trying to say. I mean, does that come into play?
100%. There's 100%. When I'm seeing a new patient, and I can kind of tell by body language and how they're looking at me, whether they're scared, whether they're angry that they had to wait, whether they're whatever. But I'd be lying if I said that and that's again that book that I'm talking about. Subconsciously, there are things that are ingrained in our heads, and they're part of our makeup, and you have to change those things. But again, I'd be lying if I said subconsciously it didn't affect me. And when you think about something, it actually can become a physical manifestation. And so you have to try. And again, we're getting too existential here, but you have to try to not think about those things.
And coming up right here on the Heart of Innovation, we are going to finish up this discussion. Wow, how time flies. Very powerful discussion. But again, we're only scratching the surface. So stay tuned. We'll have more when the Heart of Innovation continues. So stay with us. Okay, we have just a few minutes in the last one, but I want to get to Amy and her story with Dr. Jones. Because I think it's important because they do have that experience. Okay, Dr. Jones. I love Stacia.
Hi, I'm sorry, you guys. One of my colleagues who actually works at the VA hospital, she's a neurologist. She just called me, one of my best friends. So I missed what you just said, Kim. I apologize.
No, I said that we were going to get Amy on really quick because we only have about 4 or 5 minutes here. But I want to get to her story with you. So I'm going to, take it back in, to, back to the, Blackfoot deception. And, you were talking a lot. Stacia, do you want to bring in Amy and get Amy's story?
Sure. Hi, Amy. I haven't had a chance to go in detail with your story about your husband and his experience, but please share with the group what happened.
Okay, hold on. Let me welcome back. Hold on. Okay. We only have 4 minutes, guys. So just FYI, we can end the show and then continue to because it's still live online, so we can let it bleed on after. No pun intended. Okay. Ready, John?
I am ready.
Okay. In 3, 2. Welcome back, everyone, to the Heart of Innovation. We've been going in quite a few different directions, just touching on here and there some of the critical gaps in care in the African-American community that some believe may be leading to an increased number of amputations, 4 times the rate of that of their white counterparts. Before the break, we had been talking with Dr. Stacia Jones, a podiatrist out of Virginia, about the Blackfoot deception. And we do have also the wife of one of the patients that wants to share her story. So I'm going to turn it over to Dr. Jones.
Real quick, Kim, wouldn't it be interesting if we had a conference that talked about this more than just 45 minutes? Oh, we do.
I know, right? It's going to be, we have a 4-part series, so make sure to go to padequity.com to register, make sure you stay up to all of these amazing discussions we're going to have throughout the year.
Hi,
Go ahead,
everyone. Amy, I'm waiting to hear your story about your husband and what happened to you guys as he was going along his journey and what happened as far as his experience with his doctors that he was seeing at the time.
Might be on mute, Amy.
Oh. Can you hear me?
Yes.
We can.
Well, my husband had some pain in his toe, and it was kind of misdiagnosed. They said it was sciatica. He went to physical therapy. They sent him to a pain doctor, wound care, and nobody really thought it was PAD. They just thought, he's a hard worker, and this is what happened, just wear and tear on his legs. And I love the doctor. We still see her. She's great. But she just didn't know what she didn't know. She hadn't seen it, I don't think, in Blackfoot. I think she'd only seen it in a Whitefoot. And there was some differences. Her nurse had told me that she thought maybe she could have caught it if John had a Whitefoot. So that led me to believe that she probably hadn't seen it in a Blackfoot.
Oh, wow.
It ultimately he ended up having a transmetatarsal amputation. It was toe after toe after toe, and they just finally took all of the toes.
Wow.
But it's sad that in this day and age that something's lacking there, that the color of his skin is kind of what they're saying or blaming it on as to why they had to amputate half of his foot.
And that's something that Dr. Jones, we've talked about leading up to this discussion as being an issue. What is education like? Are there an equal number of cadavers to represent the diverse communities when it comes to vascular and podiatry?
I remember you guys talked about this the other day. I actually don't remember seeing maybe one African American cadaver in my lab my first year of medical school. So I definitely don't think the cadavers are diversified. And I did go to a minimal invasive surgery conference in November, and I think we had one African American cadaver there at that conference. As far as what I wanted to say is, I'm really shocked that he went to a wound care center. Is that what you said, Amy?
Well, he went to our nurse practitioner, and she sent him to wound care. But that was after he went to a pain doctor, after he went to physical therapy doctor.
So who diagnosed the PAD? Was it wound care? Because I would assume wound care would have been the people to catch it.
Well, they cut open the wound. When my husband first went to wound care, it looked like a piece of black pepper on his foot. That's what, and they cut it open, and it kind of made it worse, in my opinion, because then his toe started, and when they started working on it, the wound doctor had said, I don't know if this will heal with the blood flow that you have. And that's kind of when we realized there's probably a blood flow problem, was at wound care. Then the toe turned, it was the pinky toe, and the pinky toe then turned gangrenous.
After they cut into it.
And then by the time they took the cast off the other one, the gangrene had kind of spread to the fourth one.
What cast? I'm sorry, he was in a cast?
Yeah, he was in a,
a CAN boot?
Yeah, he was in a boot.
Okay, but you guys weren't looking at his toe every day? Was the dressings on his foot and you didn't have access to look at his toes?
Well, okay. The first doctor, they looked at, for the pinky, they looked at, okay. The fourth toe, this is where the nurse practitioner had some issues with the doctor that cut the fourth toe, because she called. He was in a splint for, I think it was 23 days before. This is post-op. He wasn't seen for 23 days after they took the fourth toe, and by then it had
after an amputation. His first post-op visit was 23 days later.
Yes. It was between 19 and 23. I have it wrote down somewhere, but it's between 19 and 23. But when I called the nurse practitioner, because I felt like even though she didn't know at first, when she figured it out, she was calling me. This is what's going on. This is what's going on. And that's why I love her. She was honest with me once she figured it out. And she called the doctor and she said, hey, I don't feel comfortable with leaving John. He's diabetic, and I don't feel comfortable leaving him wrapped for that many days. And they basically told her to mind her business.
What state? Where's this location-wise?
Indiana. Yeah. And so by then he needed all of them cut off.
Yeah, I don't know. I don't know
You
about
left
you,
her
Dr. Phillips,
speechless.
but I've never, maybe one patient, and that wasn't my fault, that I don't see within 1 or 2 weeks post-op of any surgery that I do.
Oh, this was every bit of 3 weeks. Every bit.
Wow.
It kind of felt like, okay. And the first thing he would always say was, we're trying to save the leg because we don't want to have to take that leg. And I'm thinking to myself, if we don't get you out of here, that infection is going to spread all through his leg, and you're going to have to take that leg.
So before they amputated that toe that started turning gangrene, the pinky toe, when did they get vascular involved to start doing what vascular needs to do if he has the clot in his leg?
The next day he had an angiogram.
Okay.
But when he went to they sent him from from our small hospital to a big hospital.
Okay.
And the big hospital said, like a week later, they did another one, and the doctor said, I don't even see where they did one. And I don't know if you can see where a doctor's done one, but she was adamant that I don't know what they were doing, but that wasn't what they were doing.
I've had that experience with some, yes, that you're questioning whether the vascular doctor even did anything for the patient.
And so then he had another angiogram, and that's when it started with this other hospital amputating the toes. The last 3 toes, didn't look like any infection. I took pictures all along the way, but I just couldn't understand. Still, I don't understand why they had to take them other 3 toes. It just still doesn't make sense because they were wiggling, they were moving, they weren't black. I'm still confused by that.
And he had the procedure done by the next vascular doctor, and that procedure did work?
No. He ended up going to another hospital where we got, Kim referred us to a doctor, and that procedure did work. But with the pain, when we talked about pain earlier, my husband had the transmetatarsal amputation, and less than 12 hours later, he was off pain medication. And he was in really bad pain because the blood flow had not been restored. So even with taking the toes, he still was in pain. And the doctor said, I'm not going to give you any pain medication because it's not working anyway. And this was in 12 hours. And I thought to myself, we got to get him out of here. You know, this man, he's dying in front of me, is what I felt like. I felt like my husband was dying in front of me. You know, they said, well, you could take a Tylenol. You just cut half of his foot off. You know, my husband's not one to want to take the medication anyway. And he's begging, crying, in pain. Hey, I'm hurting. And it wasn't working. So I keep giving it to him, is what they said.
Is this part of what we were talking about earlier, that maybe there's this bias, this perception that people of color have a higher pain tolerance and just don't need it? Do you think?
I think so. That's what I wanted to touch on earlier, was how they did. I mean, I hadn't even left the hospital, so it may have been 8 to 12 hours after.
And he didn't have neuropathy, your husband?
Yes, he had neuropathy. I mean, he still has it, but now with his blood flow, he's good. Yeah.
So I know, like my supervisor, for example, he's not that type of person. If someone's missing 2 of their 5 toes, he's all for, let's just do a TMA and be done with it. I am a school of, I'm gonna try to save every little toe. I'm gonna try to keep the foot, keep as many toes on that patient as possible. So he's a podiatrist as well, but he's also my supervisor, and he does not believe in that. He's like, let's do a TMA, and that's his whole thing, just cut off all the toes. And that's he's a lot older than me, and that's his school of thought, and that's how he thinks.
This guy was really young, in his 20s, I think. They said he was the best they had. His father had been a head doctor here, and you could trust him, and this, that, and the other. But no, my husband, we seen a guy that my husband, because we were an hour and something away in his office, and we seen another guy that my husband had worked with. And what were the odds to run into him that far away at a doctor, you know? And he took both of his legs, and my husband said, Amy, I just feel like if I don't get out of here, I'm headed there. You know?
And that's where you found the way to my heart, right?
Yeah.
You went searching online. And at one point, I remember that you'd gotten the blood flow restored, and they wanted to take even more. They wanted to amputate more at some point. And you said, Kim, I don't know what to do. And Dr. Natarajan, who ended up with the one that revascularized for him, said, no, get him here. And then I don't remember what happened.
My husband checked out of that hospital 3 hours away and headed down the interstate.
And he saved his leg.
He saved his leg. Yeah.
But with all these different stories from all different parts of the country, I think we all can admit that there is a problem, and that's why we're discussing this, to address the problem. And we don't just want to have a sounding board that these are all the things wrong. We want to come up with real, tangible solutions to bring an end to these disparities.
Yeah.
Definitely. And so if you want to join in on this discussion, go to padequity.com and go ahead and register. And we are going to be holding these types of discussions all year long, and we're hoping to come up with some real tangible solutions. Thank you so much to everyone for joining us today, for the amazing, powerful conversation, your courage, for being here and being so honest and candid and sharing. Thank you so much, everybody.